Hello everyone. So today I shall be discussing with you the topic platelet disorders. But before we go to the platelet disorders, we'll first learn about the platelet physiology. This is platelet physiology. So after we go to the platelet physiology, then we'll come to the discussion of the platelet disorders, which are categorized into two groups: quantitative and qualitative. Right. So let's first start with the platelet physiology. So we'll start with the process of thrombocyte formation. Thrombocyte is your platelet, and the process by which it is formed, it is known as thrombopoiesis. Right. So thrombocyte formation is thrombopoiesis, platelet formation. Well, the starting cell in this is the hematopoietic stem cell. Hematopoietic stem cell, which is a multipotent stem cell, sometimes called pluripotent stem cell. So in some books you'll find it written pluripotent, in some books you'll find it written multipotent, but it is pluripotent. Consider it is pluripotent. Pluripotent stem cell. This hematopoietic stem cell will divide into two groups. One, HSC again, so that their numbers stays remain, and the second cell that is formed. So this is the first cell, this is the first cell, this is the second cell. This second cell can be either a common myeloid precursor, also known as common myeloid progenitor, common myeloid progenitor, and second category is CLP, that is common lymphoid progenitor. So so hematopoietic stem cell will become hematopoietic stem cell so that their numbers are maintained in the bone marrow, and this process obviously happens in the bone marrow. So I'll go from the hematopoiesis and then I'll come to thrombopoiesis. So this hematopoietic stem cell will become your common myeloid progenitor or either common lymphoid progenitor, depending on the stimulus. This common myeloid progenitor gives rise to erythrocytes, that is RBC. This gives rise to platelets, PL in short, and granulocytes. Common myeloid gives RBC, platelet, and of WBCs, granulocytes. And common lymphoid progenitor will give you B lymphocyte, T lymphocyte, and natural killer cells. This is the function of common. Okay, let me increase the brightness. This common lymphoid progenitor will give you B cell, T cell, and natural killer cells. Okay, and the common myeloid progenitor will give you RBC, platelet, and granulocytes. Granulocytes other than lymphocytes, rest are granulocyte, यानी कि your neutrophil, basophil, eosinophil. The fourth category cell that it gives rise to is monocyte, because monocyte is not a granulocyte. So neutrophil, basophil, eosinophil, these are granulocytes, and monocyte is the fourth category cell produced by the common myeloid progenitor. RBC, platelet, granulocytes, that is neutrophil, basophil, eosinophil, monocytes, and common lymphoid progenitor will give rise to B cell, T cell, and NK cells. B cell is B lymphocyte, T cell is T lymphocyte, NK cell is natural killer cells. What stimulates the formation of RBC is erythropoietin. What stimulates the production of platelet is thrombopoietin. And what stimulates the formation of granulocyte is GCSF, granulocyte colony stimulating factor. And what stimulates the monocyte is MCSF, monocyte colony stimulating factor. Now let us discuss about the thrombopoiesis process in detail. So we know it comes from the common myeloid progenitor. The common myeloid progenitor will again divide into two cells. One will be common myeloid progenitor, and the other cell will become your dedicated cell that will form the mega platelets ultimately, that is thrombocyte. So the first cell in this is megakaryoblast. This megakaryoblast will become promegakaryocyte. Clear? Megakaryoblast. So first cell is the blast cell, then cyte. So from blast it becomes cyte, but it is a procyte. So first remember is blast, then procyte, then cyte. So promegakaryocyte will become megakaryocyte. So first is a blast, obviously megakaryoblast, then procyte, promegakaryocyte, and then just cyte, megakaryocyte. This megakaryocyte will give rise to platelet, because megakaryocyte is a nucleated cell. It has a nucleus, but the platelets don't have nucleus. So what is platelet then? It is the shed off of the cytoplasm of megakaryocyte. This cytoplasm will get pinched off, and this is your thrombocyte. So that is what is thrombocyte is. Remember, in this lineage, so from blast to procyte to cyte, take a first cell is megakaryoblast, then promegakaryocyte, and then megakaryocyte. The cell size is increasing continuously. So the largest cell in this is megakaryocyte. This is the largest cell. Okay, this one is small, this one gets large, and this one becomes largest. So from small, large to largest. Okay, and then thrombocyte comes out. Thrombocyte is very, very small. It is just 2 to 3 micron. Okay, very, very, very small cell which has disc shape. Okay, so things about platelets that we know. What do we know about the basic information of platelet? That is, it is just the cytoplasm that has pinched off from the megakaryocyte. Size, the size we know, it is between 2 to 3 micron. What is the shape? If it is not active, it is disc shaped. When it becomes activated, it becomes irregular in shape, like a sea urchin. Then, is there any nucleus? Answer is no, no nucleus. Size 2 to 3 micron. So size, shape, and nucleus. Then its granules. It contains alpha and dense granule. Alpha and dense granules. Okay, so alpha granules are not producing, what the alpha granule contain is von Willebrand factor, platelet derived growth factor, coagulation factor, fibrinogen. 4 things. They are all factors. Factor, fibrinogen you can also think of it. Von Willebrand factor, platelet derived growth factor, coagulation factors, fibrinogen. Alpha is all about factors and fibrinogen. Alpha is all about F. And dense granule has ADP, ATP, calcium, 5-HT, serotonin. So dense has ADP, ATP, calcium, and serotonins. So alpha granule and dense granule. What is the lifespan of platelet? Lifespan platelet is just 8 to 10 days. This is the lifespan of platelet. The platelet membrane, the membrane of platelet is rich in glycoproteins like GP1B and GP2B3A, which are important for the qualitative disorders. We will study how these glycoproteins, these are glycoproteins. What are they? Glycoproteins. These glycoproteins which are present in the membrane, they are responsible for the important process of hemostasis. We will study them. Okay, but if I ask you, does RBC has nucleus? Your answer is no. Does RBC have mitochondria? Your answer is, the answer is no. RBC does not have mitochondria. So no nucleus, no mitochondria. About platelet, nucleus, no. About platelet, does it have mitochondria? Yes, it has mitochondria. That is the difference of RBC and platelet. Again, the shape is different, obviously the size is also different. It is about 7 micron in size. This one is just 2 to 3 micron, and it is concave shape. This one is just disc shaped. This one has lifespan of only 8 to 10 days. RBC has a lifespan of 120 days. RBC 120 days. Platelets just 8 to 10 days. Size of platelets 2 to 3 micron. RBC 7 micron. Shape of RBCs biconcave, does not have mitochondria. Platelets have mitochondria, it is disc shape. Why RBC does not have mitochondria? Okay, so just ask question I'm asking. Why RBC doesn't have mitochondria? See, mitochondria, what is the function of mitochondria? Is to use oxygen. Correct? What is the purpose of RBC in our body? Is to carry oxygen by attaching it with hemoglobin. So if RBC contains mitochondria, then what will happen? The carried oxygen will be used up by the RBC itself. So RBC only wants to carry oxygen, not use it. So no mitochondria. This is very, very important. So by removing the mitochondria, it gets more space to carry the oxygen. Now let us discuss about another important topic in physiology of platelets. So formation we have studied. Now let's talk about hemostasis, how it works. Understand what is hemostasis is. Right, suppose there is some injury, okay, and due to this injury there is leakage of blood from the blood vessels. So the stoppage of that bleeding is known as hemostasis. Bleeding stop, hemostasis. So it has 4 phases. First is vasoconstriction. Second is known as primary hemostasis. Then the third step is known as secondary hemostasis. Primary hemostasis is platelet plug formation, and this is coagulation cascade. That is fibrin mesh formation, also known as fibrin mesh formation. So this is platelet plug formation. This is the second step of hemostasis. First step is vasoconstriction. Second step is platelet plug formation. Third step is fibrin mesh formation, and the fourth step is clot retraction, because most of the time the clot becomes big. So clot retraction, that is the fourth step. What does the clot retract? It is because the platelets shrink in size. So clot retraction is due to the platelets shrinking in their size. Okay, how does it happens? So platelets have these proteins known as actin, myosin. These proteins helps to shrink the size of platelets, resulting into clot retraction. So vasoconstriction, primary hemostasis, secondary hemostasis, and clot retraction. Primary hemostasis is platelet plug formation, secondary hemostasis is fibrin mesh formation. Finally, after hemostasis is over, the last step, which can be considered as the last step, but it is obviously going to happen after the clot has been formed, is clot removal. Clot removal और fibrinolysis. देखिए फिब्रिन मैश को ख़त्म करो, removing the fibrin mesh, clot removal. So what happens in vasoconstriction? It is due to the smooth muscle cell. The smooth muscle cells which are present in the vessel wall, they will immediately contract. So this is a neuronal mechanism. Immediate reflex contraction of this smooth muscle cells which line the vessel wall, okay, which is due to the release of endothelin from the endothelial cells. So endothelial cells which are lining, so suppose this is the vessel, these are the endothelial cells. Beneath the endothelial cells is your connective tissue, and then we have the smooth muscle cells. These spindle cell structures are the smooth muscle cells. So this endothelial cell will release something known as endothelin. Once they are injured, endothelin will be released, and this will trigger the smooth muscle cell to contract. Okay, this is first step. This is vasoconstriction. So this is mediated by endothelin. Then platelet plug formation. In the platelet plug formation, that is the primary hemostasis step. So there are few steps within the platelet plug formation. First step is adhesion, followed by activation, followed by aggregation. So adhesion, activation, and aggregation. What is adhesion? The platelets, suppose this area is damaged, so platelets were traveling in this area, the platelet will get exposed to the collagen. So this thing is collagen, okay, and this is platelet. Suppose कहीं पे damage हो गया, some place is damaged, suppose. So what will happen? This underlying collagen, okay, this underlying collagen will get exposed by the platelets. The platelets will be exposed to the underlying collagen, and hence as a result what will happen? The platelet will adhere. So first step is adhere. The platelets will adhere to this exposed collagen, and there are certain factors which help in the binding. So in the platelet with the collagen, how it will bind? So the binding process is like this. Suppose this is the platelet. The platelet has a receptor known as GP1B receptor, and then this collagen has von Willebrand factor. This is the von Willebrand factor. This is platelet. So platelet, GP1B, then von Willebrand factor. This is platelet adhesion. This is adhesion. Then after adhesion will be activation. Platelet activation, what happens? The platelets change shape and they become like this, spiky. So this is the activated platelet. This activated platelet will pour out its granules outside. The granules which are containing the dense granules like ADP, ATP, calcium, 5-HT, that is serotonin. These are the contents of dense granules. So dense D for this is delta. Okay, dense granule is also known as delta granule. So dense granule or delta granule will release these things that will help in the platelet further activation. So this platelet this platelet is bound, this platelet is activated, this activated platelet will release these structures, these products from this from its inside, and this will activate further cells. This will activate further platelets. The purpose of these granules, these molecules, ADP, ATP, calcium, okay, all of this is to attract or recruit more platelets. So their function is to recruit more platelets. They will recruit more platelets, and these platelets will now become sticky. Before I come, but first I have to know how does von Willebrand factor came here. So this is the endothelial cell, right? This endothelial cell has something known as Weibel palette bodies. This endothelial cell has Weibel palette bodies. These Weibel palette bodies are present both in the endothelium, that is endothelial cells. They are also present in the platelet. Okay, they both have this. I'm saying wrong. They both have von Willebrand factor. The endothelial cell has Weibel palette body. The endothelial cell has Weibel palette bodies, which is releasing von Willebrand factor, but platelets releases von Willebrand factor from their alpha granule. We remember in the alpha granule VWF is present, von Willebrand factor, but endothelial cells also has von Willebrand factor, and that is released from the Weibel palette bodies which are present in the endothelial cells. When the vessel is injured, obviously the endothelial cell will be also injured. This cell will also be injured. This injured cell will now release von Willebrand factor, and this von Willebrand factor will act as a bridge between the subendothelial collagen and platelet, and this is the subendothelial collagen. The von Willebrand factor, which is released by the, suppose this was the vessel containing endothelial cells, these are endothelial cells, they are released, they are damaged. Suppose here it is damaged, so this damaged endothelial cell, suppose this damaged endothelial cell released von Willebrand factor. So this platelet with GP1B receptor, this is GP1B, along with the von Willebrand factor which is produced by the endothelial cell, will bind to the subendothelial collagen. This is subendothelial collagen. So this von Willebrand factor acts as the bridge between the platelet and the subendothelial collagen, and the defect of von Willebrand factor is known as von Willebrand disease. If this protein, that is GP1B, is defective, this is known as Bernard-Soulier syndrome. Bernard-Soulier syndrome. GP1B defective, von Willebrand factor we all know, very simple. So this is platelet addition. After addition, the next step is activation, and after activation the next step is aggregation. Okay, now let's come to activation. So it is adhered. Now activation, once adhered, the platelet, that platelet will get activated. That platelet which has adhered will get activated. It will change its shape from the smooth disc shape and will become a sphere which has spikes. Okay, and this activated cell will release granules. This process is known as degranulation, that is release of the granules. Now in degranulation it will release ADP, calcium and thromboxane A2. These three are most important. ADP, calcium, we know they come from the delta granule, but thromboxane A2, this is produced only when the platelet is activated. Only when the platelet is activated it will release thromboxane A2. This thromboxane A2 is the most important now. This thromboxane A2 promotes in aggregation. The next step, that is after activation. This is the second step. The third step is aggregation. This thromboxane A2 that is produced will help in aggregation. This ADP will call other platelets to come. This ADP will act as a signal for other platelets to come, and once they come, this platelet and this platelet will get attached to each other with the help of, in the center, what is it? It is thromboxane A2. This thing in the center is thromboxane A2, and these receptors are GP2B, GP3A. These receptors are GP2B, 3A receptors, which oh sorry, one thing I am mistaken. This is not thromboxane A2 that is in the middle. This is fibrinogen. Fibrinogen is in the middle, and GP2B, GP3 receptors are there, which are responsible for the formation of the bridge. So activated platelets, these are all activated platelets. These activated platelets will bind to each other using the GP2B, GP3 receptor and the fibrinogen. This fibrinogen is acting as the bridge between the adjacent platelets. But the process of aggregation is mediated by thromboxane A2. Thromboxane A2 helps in the process of aggregation. The defect in this gene is known as, this gene that is producing the GP2B, GP3 receptor is known as Glanzmann thrombasthenia. So Glanzmann thrombasthenia, these three, Glanzmann thrombasthenia, Bernard-Sollier syndrome and von Willebrand disease, these are your qualitative disorders. So we now understand what is the process of platelet plug formation. If I tell you how the anti-platelet drugs work in preventing platelet plug formation, so aspirin, how it works, and clopidogrel, how it works. These two are the most important antiplatelets. We use double anti-platelet therapy, DAPT. Sorry, we use this double anti-platelet therapy. This double anti-platelet therapy, which contains aspirin and clopidogrel, how aspirin works and how this one works. So aspirin is inhibitor your COX-1 enzyme, cyclooxygenase 1 enzyme. This cyclooxygenase enzyme is responsible for production of thromboxane A2. So by giving aspirin, by inhibiting the cyclooxygenase 1 enzyme, we are decreasing the production of thromboxane A2. That means it will inhibit the platelet aggregation, because thromboxane A2 is mainly responsible for aggregation. Then clopidogrel, which is a P2Y12 inhibitor. P2Y12 inhibitors are inhibitors which are ADP receptor blocker. So see how it works, how ADP helps in this process of aggregation. Okay, suppose this platelet, which is activated because it has been exposed to the subendothelial collagen. Okay, on the surface of it has GP1B, then it is attached to von Willebrand factor, and this is the subendothelial collagen. This is the subendothelial collagen. Okay. Now this activated platelet will release ADP, calcium, and thromboxane. These are the three most important. What ADP does? What ADP does is that it tells this cell, which is a platelet, to express GP2B3A receptors. This ADP tells this platelet, which is not expressing the GP2B3A receptor, to express GP2B/GP3 receptors. Secondly, it brings more platelet into the picture. So ये जो platelet है, this platelet, it came due to ADP. So it did two things. First, it brought, number one, it brought more platelet, and second, expression of the GP2B3A receptors. This exact same function is also done by thromboxane A2. Thromboxane A2 also brings more platelets and induces the expression of GP2B/GP3 receptors. So both ADP and calcium and thromboxane A2, both ADP and thromboxane A2 brings more platelet and expresses the GP2B/GP3 receptor. So finally, our platelet plug is formed, right? Okay, platelet plug is formed, but this is a temporary plug and it will be later stabilized by fibrin mesh, which we will not go into detail. Okay, the secondary hemostasis, for that there is a separate video on hemostasis, but I was telling you how the clopidogrel or the P2Y12 receptors work, because clopidogrel is your P2Y12 receptor antagonist. Okay, P2Y12 receptor blocker. Examples of such drugs are clopidogrel, prasugrel, ticagrelor, clopidogrel, prasugrel, ticagrelor. They are P2Y12 inhibitor, or also known as ADP receptor blocker. That means that platelet which was coming to the site of action, because here is a activated platelet, this activated platelet is bringing more platelet to that bleeding site. How? With the help of ADP and thromboxane A2. They were both bringing more platelets and also telling them to express GP2B3A receptors. But by blocking the synthesis of thromboxane A2 with aspirin and by blocking the ADP receptors, because this platelet was releasing ADP and this ADP was binding to a receptor, the ADP receptor. Once it was binding to the ADP receptor, this ADP, once it was binding to the ADP receptor, it was telling this platelet to come to the site of action and also to express the GP2B3A receptors. But now with the double antiplatelet therapy, that is giving aspirin as well as a P2Y12 inhibitor like clopidogrel or prasugrel or ticagrelor, we will be able to inhibit the formation of platelet plug in patients who are at risk of having platelet plugs formation. Especially patients who had previous episode of MI or stroke, in them DAPT is given. Okay, in a patient with MI or any sort of acute coronary syndrome. Acute coronary syndrome includes three things: STEMI, non-STEMI, there is non-ST elevation MI, and last one is unstable angina. In these three conditions, it is prescribed for 12 months. Double antiplatelet therapy is prescribed for 12 months. Okay, but for stroke patients, it is prescribed for 3 months maximum, 1 to 3 months. So these are the mainly two important areas where it is indicated. One is stroke, other one is acute coronary syndrome. For stroke, 1 month to 3 months. For acute coronary syndrome, up till 1 year.